So next is upper GI surgery, chapter 8. So we're talking, the first topic is Achalasia V1. So before discussing into the achalasia, there are some basic sciences. So what is histology in achalasia? So primary achalasia is due to the progressive loss of ganglionic cells in the myenteric plexus, particularly with severe loss of inhibitory neurotransmission, and it's unknown of cause. And there is a classification called Chicago classification. It's based on the manometric studies. It has three types: type 1, type 2, type 3. Type 2 and type 3 are the worst, and type 1 is a classic, and it's a 100% failed peristalsis and a lower esophageal sphincter that fails to relax completely. And type 2 pan-esophageal pressurization to 30 millimeter of mercury with at least 20% of swallows and no normal peristalsis. And type 3 is the no normal peristalsis, preserved fragments of distal peristalsis, or premature contraction in more than 20% of the swallows. So now our scenario: a 51-year-old female complains of dysphagia, internal pain on swallowing, and regurgitation of food. Discuss your management. So I would take history, duration of symptoms, any difficulty in swallowing with fluids or solids, and need associated respiratory problem due to regurgitation, and these presenting symptoms suggest a possible diagnosis of achalasia. Next is clinical examination, that is will be normal, and then I will arrange an endoscopy that will show tight distal space. I will do an urgent endoscopy to exclude pseudoachalasia due to the distal esophageal tumor. In early achalasia, the typical finding of dilated esophagus containing undigested food and tight gastric cardia may not be seen. If achalasia is suspected, the gold standard investigation is esophageal manometry, which will show hypertensive, non-relaxing lower esophageal sphincter in response to the wet swallows and loss of peristaltic activity in the esophagus. So one is the whole body of esophagus, where will be loss of peristalsis, and one is the lower esophageal sphincter, which will be unable to relax. So the endoscopy and manometry studies confirm achalasia. What are treatment options? There are three main treatment options: botulinum toxin, medullary dilatation, surgical, and endoscopic. That's four actually. So I would reserve the Botox injections for patients who are unfit for surgery, as they are the least effective in the long term, and 6 to 12 months. And the medullary dilatation is initially effective in up to 90% of the patients, but often needs requiring. At 5 years, surgery and medullary dilatation have equal successful rate, more than 80%. But 20%, 25% of the patients with medullary dilatation, they need repeat procedure, and there are 2% risk of perforation. Surgical cardiomyotomy is a definitive treatment in non-dilated or minimally dilated esophagus. Cardiomyotomy is successful in 80%, more than 80% of the cases. The novel per-oral endoscopic myotomy has excellent short-term results, but no long-term data yet available. Briefly describe how you perform a surgical cardiomyotomy. So laparoscopic anterior myotomy with from gastroesophageal junction continually distal to no further than 2 cm on the stomach, and I will ensure that the muscle fibers of esophagus, lower esophageal sphincter, and cardia are adequately divided, and it will expose the underlying mucosa without breaching it. Simultaneously, I will perform anterior reflux procedure. It will be in the form of partial anterior wrap, because there is a high risk of gastroesophageal reflux after division of the lower esophageal sphincter. And total fundoplication is often avoided because of the aperistaltic esophagus and increased risk of post-op dysphagia. What determines the extent of your proximal esophageal myotomy and why? As long as the thickened musculature lower esophageal sphincter system is divided, the proximal extent is less important. However, most surgeons will perform a minimum of 6 centimeter at the proximal myotomy. The myotomy should not extend high into the mediastinum, limited due to the restraints in ability to suture repair a high mucosal breach, and consider water soluble contrast to exclude the mucosal breach. Thank you.